we'll go ahead and invite Ms. Baldwin and Ms. Hawkins up to resume the direct examination.
Just let me know when you're ready.
I'm ready.
Okay. So let's move on to behavioral health workforce development. Is this part of the abatement plan that you and Commissioner White developed?
Yes.
And can you explain to the court what the purpose of behavioral health workforce development is and why it's necessary?
Yes, there has been rightfully so recognition nationally and in our state as well about the opioid crisis really amplifying the need for qualified behavioral health providers in communities and magnifying where there are gaps, not only in our state but across the country. And we've seen some federal calls and others to make sure we identify methods to incent behavioral health clinicians to work in the field of substance use disorder treatment, specifically to provide medication-assisted treatment services, and also, as it relates to our state, to ensure that we have providers in rural communities where we often have serious gaps in services and our ability to get providers into those areas. So this particular component of the plan is to develop a loan forgiveness and tuition reimbursement program to incent mental health professionals, licensed or under supervision, and other practitioners to work in underserved areas and high-need areas of the state.
And so can you describe the services that are in this component of the abatement plan and the associated costs and how the costs were arrived at?
Yes. So the first line of this component is for student loan reimbursement. There is a program that the state of Indiana has launched to place and reward, if you will, or incent behavioral health providers in high-need areas for opioid use disorder treatment. And this particular service was modeled after Indiana's program. This would be an effort to provide student loan reimbursement to at least 100 licensed applicants for $20,000 each year. And the amount would be determined by the profession or the licensure of the individual. And so this portion of the plan totals $2 million.
And what is the tuition assistance portion?
The tuition assistance program is also an area where our agency or other agencies that are looking for methods to grow or develop licensed or master's level clinicians to provide these services in certain parts of the state. This particular program would be for state agencies like the Department of Mental Health or others to provide tuition assistance to about 100 applicants in graduate courses in programs leading toward licensure. And the amount would be up to $5,000 each year. And so the cost for this program would be $500,000. There is also a administrative cost to overseeing this program, setting up an application process, monitoring and making sure that those who are selected to be part of this program are fulfilling their requirements under the program at a cost of $75,000 per year.
And what is the total cost in 2019 dollars for this portion of the abatement plan?
The total cost is $2,635,770.
And based on your education, skills, experience, and training, do you believe that the behavioral health workforce development services that you described today are necessary to abate the Oklahoma opioid crisis?
Yes, they are necessary.
And do you have an opinion as to whether the costs that you described for this program are reasonable and necessary expenses to implement this program?
Yes, they are reasonable and necessary.
Is neonatal abstinence syndrome evaluation and assessment part of the abatement plan that you and Commissioner White developed?
Yes.
And can you explain to the court what the purpose of NAS evaluation and assessment is and why it is necessary?
Yes. As neonatal abstinence syndrome becomes a more pressing burden on hospital systems and healthcare providers, there needs to be continual standards in place in Oklahoma hospitals so that they are capable and competent of recognizing NAS, documenting NAS, providing services for these infants and the mothers. In this particular component of the plan, we have identified a national program of quality improvement called the Vermont-Oxford Network Quality Improvement Package. And this particular program would provide intensive training and support to Oklahoma birthing hospitals to help certify them or accredit them as centers of excellence in NAS evaluation and assessment. The University of Oklahoma Health Sciences Center has elevated this to be part of the plan and would oversee as part of their perinatal quality improvement project this particular program. And so in this component of the plan, there are costs for actually obtaining a license to the Vermont-Oxford Network Quality Improvement Package for the state of Oklahoma at a cost of $52,000, and then the personnel to oversee and coordinate, enroll, and recruit sites into this particular accreditation program at a cost of $100,000 for staff time, salary, and benefits.
And based on your education, skills, training, and experience, do you believe that NAS evaluation and assessment is necessary to abate the Oklahoma opioid crisis?
Yes, it is necessary.
And do you believe that the costs that you've described here today for this program are reasonable and necessary expenses to implement this program?
Yes, I think they're necessary and very reasonable. This is a very high quality program at a very reasonable cost.
Is prenatal screening part of the abatement plan that you and Commissioner White developed?
Yes.
And can you tell the court what is the purpose of prenatal screening as it's set forth in the abatement plan, and why it's necessary?
Yes. I testified earlier in the abatement plan around the component on universal screening for primary care offices and for emergency departments. And that was to widely disseminate the use of this evidence-based approach called SBIRT, screening, brief intervention, and referral to treatment. That particular intervention is also highly applicable to pregnant and postpartum women. In fact, the American College of I think it's ACOG, whatever that stands for, recommends that universal screening be in place for pregnant women and postpartum women. And what this does essentially is allows for a practice dissemination program to be offered in the state of Oklahoma to the 150 birthing hospitals, and in addition to that, OBGYN offices.
And can you explain to the court, this is broken down into two components, is that correct?
Yes.
And the first component is SBIRT practice dissemination, and the second component is universal screening for pregnant women, is that correct?
Yes.
So let's talk about SBIRT practice dissemination first. Can you explain to the court what that is and how the costs were arrived at for that component of this section of the abatement plan?
Yes. So similar to the practice dissemination for primary care and emergency departments, this program would allow 352 OBGYN offices in Oklahoma and 150 birthing hospitals in Oklahoma to enroll in this program, where they would be matched with a practice facilitator. They would receive academic detailing and training in clinical guidelines for the recognition of substance use disorder, opioid use disorder in pregnant women. It would also assist in with referrals and managing opioid use disorder treatment with pregnant women. There are specific guidelines and protocols that are followed for the treatment of opioid use disorder with a pregnant woman, and these are not entirely simple protocols. And so to have these sort of supports in the practice and in the hospital are necessary in order to embed screening. So the first part is for the practice dissemination. In the first year of this program for these sites, it would be a cost of $25,000 per site for a total of 197 sites. The cost would be $4,925,000. In years 2, 3, 4, and 5, the practice dissemination program would go down and cost $6,250 per site times 197 eligible sites at a cost of $1,231,250 per year. Then at the 5th year, or after the 5th year, this cycle repeats again. From my earlier testimony, to make sure that the clinical guidelines may have changed, research, other sort of clinical practices that need to be updated, turnover in hospital and practice staff. It's necessary that these quality improvement projects continue in the healthcare setting. They should be ongoing. The second part of this component in the plan is to support the cost of screening services for Sooner Care members. The Oklahoma Health Care Authority provided us the cost for alcohol and substance use disorder screening and brief intervention. On the lower end of the intervention for 15-30 minutes, the cost for that service is $30.96. They are proposing and estimating the number of eligible Sooner Care pregnant women would be 51,812. And those women would be eligible for one of these assessments and interventions per year at a cost of $1,604,100. In addition, these Sooner Care members would also be eligible alcohol and substance use screen and an intervention lasting greater than 30 minutes should it be necessary at a cost of $60.20 per encounter, multiplied by the number of eligible Sooner Care members for a total of $3,119,082. And then finally in this section, like in the other section, these patients would also be eligible for 2 additional screens where the outcome potentially, if they were negative for those screens, the provider would still be compensated for that service at a rate of $3.53 per encounter for those screens for a total of $365,793.
And based on your education, training, skills, and experience, do you have an opinion about whether prenatal screening is necessary to abate the Oklahoma opioid crisis?
Yes.
And what's your opinion?
It is necessary.
And based on your education, training, skill, and experience, do you have an opinion about whether the costs you described for this component of the abatement plan are reasonable and necessary expenses to implement this program?
Yes, they are reasonable and necessary.
And do you believe the costs that you just described for universal screening for pregnant women are conservative?
Yes, I do. In fact, in this case, for example, for the screening costs, the actual screening services, this plan contemplates only serving Sooner Care pregnant women and not all pregnant women in the state of Oklahoma. In addition to that, the practice dissemination program is a way in which we hope and we plan that practices will learn how to implement this model and be able to serve other pregnant women in the state.
Is neonatal treatment a part of the abatement plan that you and Commissioner White developed?
Yes.
And can you tell the court what is the purpose of neonatal treatment and why is it necessary?
So you've already heard testimony about the experience of an NAS birth and the complications that happen for the baby and for the mother in those cases. The fact is that medical treatment for infants born with NAS or suffering from opioid withdrawal is complex, and it's more expensive than a typical ordinary birth. In this case, what this component of the plan is requiring is that these additional costs above and beyond what an ordinary birth cost would be if the child did not have NAS would be covered.
And is that cost differential between what an ordinary birth costs and what an NAS birth costs, around $63,000?
Yes. Yes, so there was a study done that estimated the cost of what an ordinary NAS birth would be and estimated it at $63,200. That was then multiplied by an average for the next 30 years of about 300 NAS births in the state of Oklahoma. And that figure was provided by another expert in this case. It's a conservative figure. We've already seen numbers from the Department of Human Services from, I believe it was 2017, that reported 500 NAS births in Oklahoma. And so it also is conservative because the cost that I'm describing at $63,000 for an ordinary NAS birth does not include medication. That would be even higher for a complicated NAS birth that requires pharmacotherapy. In addition to that, this particular component doesn't include treatment for the mother, and it also does not include ongoing services, medical expenses for the child in the first few years or even more into life.
And when you said DHS provided the numbers for babies born with NAS, do you mean OHCA?
Oh, yes. Authority? Thank you. Yes.
And based on your education, skills, training, and experience, do you have an opinion whether neonatal treatment is necessary to abate the Oklahoma opioid crisis?
Yes.
And what is that opinion?
It is necessary.
And based on your education, skills, training, and experience, do you have an opinion on whether the costs for neonatal treatment that you just described are reasonable and necessary expenses to implement this part of the abatement plan?
Yes, they are reasonable and necessary.
Opioid Overdose Review Board, is that a part of the abatement plan that you and Commissioner White developed?
Yes.
And can you explain to the court what an Opioid Overdose Review Board is and why it is necessary?
Yes. In many states, there are boards that review premature, unusual deaths in order to not just document those deaths, but to walk back and really look at individual cases and understand the context of those deaths. The ultimate goal being to monitor trends, produce reports, and recommend interventions. They are looking for opportunities to identify ways in which that life could have been saved. So in our state, for example, we have domestic violence fatality review boards, child death review boards. In this case, it has been a recommendation of the state that we have an opioid overdose fatality review board. This particular component would require 2 full-time people to coordinate this fatality review board. Their responsibilities would be to get data on the deaths, not just from the medical examiner report, but multiple indicators, including, for example, health records, potentially interviews with family, looking at prescription histories. There could be any number of things, military status, correctional status of this person, dozens and dozens of indicators in order to really paint a picture of the decedent to understand what led to that death. In this case, this particular review board will have a lot of cases to review. And so this requires 2 full-time professionals to oversee this process. They not only pull down this data, they then review those cases and they prepare them for the board to review. So they select cases and they identify themes to elevate to the board. These coordinators also produce reports. They coordinate with the state health department, for example, and the chief medical examiner's office, and then put forward recommendations for actions. In some cases, board members may even work on coordinating interventions themselves if that becomes necessary.
And the total cost for these 2 coordinators?
It is for salary and benefits of $79,795 per person at a total cost of $159,590.
And based on your education, training, and experience, do you believe that an opioid overdose review board is necessary to abate the Oklahoma opioid crisis?
Yes.
And do you have an opinion on whether the costs that you just explained are reasonable and necessary costs to implement this part of the abatement plan?
Yes, they are reasonable and necessary.
Is PMP system upgrades part of the abatement plan that you and Commissioner White developed?
Yes.
And can you explain to the court what the purpose of PMP system upgrades is and why it's necessary?
Yes. Yesterday, I talked about the history a bit of Oklahoma's prescription monitoring program. Oklahoma has one of the best systems in the country and has for many years. As the problem has progressed and as the opioid crisis has really taken hold, we have looked at opportunities in the state, and the Bureau of Narcotics has done an excellent job of identifying ways of better utilizing that data to help address the crisis and to engage partners such as the Department of Mental Health and the State Health Department in analyzing that data and improving upon it continually. So this particular component of the abatement plan is to not only fund Oklahoma's PMP system, which is called PMP Aware in the state, but also to provide the resources necessary to oversee the administration of the PMP system, to assist in data analytics on the PMP system, to improve upgrades to the system, developing things like proactive alerts, additional proactive alerts to the system, looking at new reporting methods, and also, in addition to that, building a team of folks at the Oklahoma State Department of Health who can use what are called the behavioral health measures in the PMP. What that is there's over 40 measures that Brandeis University has identified as being things that a PMP could be analyzed for in order to use PMP data for prevention or for public health interventions or for treatment interventions. And in order to do that, it requires that we have the staffing in place and the ability to pull out the right data and to examine it in order to utilize those indicators in that way.
And so, just described is broken into 2 parts: one for OBN and one for OSDH. Is that correct? The court through how you came up with the costs for these services and personnel that relate to OBN.
Yes. So first line in this component for the PMP system itself is to support the cost of the PMP system and any ongoing maintenance for that system at a cost of $443,227. The second part of this is for upgrades and integrating the PMP into electronic medical records. Right now, providers in most cases maybe querying the PMP, and they're also working in their local practices EMR or their hospital EMR. They even may have a third system that they're entering data into when they're seeing a patient. This integration process really does assist with the provider's workflow. It increases the likelihood that the provider will check the PMP and will get the data in a very timely and efficient way so that they can look at that data and make a clinical decision about the patient that is in front of them. And so there are costs associated with integrating this PMP into electronic medical record systems in Oklahoma, which is $600,000. In addition to that, there are data extracts fees when the Bureau of Narcotics or other agencies that may be working in this data require special reports or require the system administrator to pull out data for analysis, particularly when that's something that's not already packaged in the program license. There are costs associated to do that, and in this plan, they're at $27,000 per year. Also included with regard to the PMP system are staff at the Bureau of Narcotics and Dangerous Drugs. First are PMP analysts. These are folks that utilize PMP data to assist compliance officers and investigators. So they are working in the PMP data and providing record or patient or provider or pharmacy level information to OBN investigators and compliance officers. They are assisting in that process. This request is for 2 full-time PMP analysts at a cost of $147,500. There's also in here a compliance trainers for the PMP. Essentially, these are PMP educators. The Bureau of Narcotics, I believe, has around 22,000 registrants, and these PMP educators make visits to doctors' offices. They speak with registrants. They teach them about the system. They help them with querying. They conduct tutorials. They do group trainings. They do phone consultation, helping providers utilize the PMP system. And the Bureau of Narcotics requires 2 additional PMP trainers at a cost of $120,000. There is also a one-time setup cost that is built into this component of the plan each year. These are costs that are required by the vendor in order to set up enhancements to the PMP. So each time the Bureau of Narcotics requests a change to the PMP system, some sort of customized reporting or other otherwise change to the system, there are costs affiliated with doing that. This particular $80,000 cost is broken into $24,000 for additional data extracts that the Bureau may request, $36,000 for configurable reports out of the system, and $20,000 for delegate audit accounts at a cost of $80,000 per year.
And can you walk the court through the personnel and non-personnel costs related to OSDH and how those costs were arrived at?
Yes. The State Health Department is expanding their role, as is the Department of Mental Health, in assisting the Bureau in studying PMP data and looking particularly at population level measures that may be helpful in designing interventions to abate the crisis. The State Health Department requires 3 epidemiologists to conduct these tasks. It may be, for example, matching data sets or records between PMP records and vital records. That could be an example of a study that they undertake. The State Health Department requires 2 epidemiologists, 3 staff full-time at $183,330. Require 1 just 2 at $76,388. In addition to that, there are per employee costs for printing within the State Health Department and affiliated with these projects, and so the cost of $10,000.
And based on your education, your training, about whether the PMP system upgrades are necessary to abate the Oklahoma opioid crisis?
Yes, they are necessary.
And based on your qualifications, do you have an opinion as to whether the costs that you've just described for the PMP system upgrades are reasonable and necessary expenses to implement this program?
Yes, they are reasonable and necessary.
Is program management monitoring and evaluation part of the abatement plan that you and Commissioner White developed?
Yes.
And can you tell the court what is the purpose of program management, monitoring, and evaluation, and why it is necessary?
Yes. In putting together this plan, we absolutely contemplated the oversight of this plan, the need for an infrastructure, a capacity to develop implementation plans, to develop evaluation plans and measures for this abatement plan, to coordinate services that are potentially funded under this plan, monitoring compliance for any entity that may be providing services under this plan, coordinating those contracts, and also monitoring progress on this particular plan. And so in order to do so, we made our best estimate, conservative likely estimate of the staffing that would be required minimally to oversee and manage and monitor this abatement plan.
So this part of the plan is broken into program management and monitoring, correct?
Correct.
So can you walk the court through the program management part of this plan, and how the personnel was selected and how the costs were arrived at?
Yes. Using our experience in thinking about what it takes to really oversee, a plan, and to make sure that it is effective and you have the proper infrastructure in place, this is the recommendation. So first, there should be a full-time director overseeing this plan at a cost of $178,900 per year. These are all inclusive of salary and benefits and are comparable to other positions within the state of Oklahoma. This would also require a finance director at a cost of $126,778 per year. There would also be an operations director, mostly overseeing staffing and contracting at a cost of $126,778 per year. There would also be 2 senior program managers that would be overseeing the individual aspects of this plan at a cost of $111,862.50 for each person per year, for a total of $223,725. There would be 4 program managers assigned to various aspects of this plan. And again, I'll reiterate, these are not the people who would actually be implementing services. Instead, they would be overseeing the administration of this plan. 4 program managers at a cost of $96,947.50 for a total of $387,790. 4 program officers in order to do contract compliance, monitoring, invoicing at a cost of $82,032.50 per employee for a total of $328,130. 2 finance officers, probably 1 for budget, 1 for payments, at a cost of $82,032.50 per year for a total of $164,065, and 2 administrative assistants at a cost of $59,660 for a total of $119,320 per year.
And how did you come up with the cost per personnel?
So those are comparable salaries and benefits for similar positions within state government.
And if we go to the next part of this component of the abatement plan, monitoring, can you explain to the court how you selected the personnel and arrived at the costs for that portion of the program management, monitoring, and evaluation section?
Yes. Again, this is conservative and doesn't necessarily take into account efforts to contract, for example, for evaluation service. This, in my opinion, would be the team of people who oversee evaluation and monitoring of goals and objectives in this plan, and document those, and also work with any sort of research or outside entity that may be assisting in following certain measures that are defined for the plan. First, there would be data staff at the Department of Mental Health and Substance Abuse Services, 5 at a cost of $89,490 per year for a total of $447,450. 2 program evaluators at the State Health Department, 1 at a level 3 at $91,665 per year, 1 at a level 2 at $76,388. In addition to that, there are per person data costs for State Health Department employees. For those 2 employees, it would be a total of $7,200 per year, and then printing costs for those staff estimated from the State Health Department at $10,000 per year.
Now, Ms. Hawkins, based on your education, training, skills, and experience, do you believe that the program management, monitoring, and evaluation portion of the abatement plan is necessary in helping to abate the Oklahoma opioid crisis?
Yes, it is necessary.
And do you have an opinion as to whether the costs you just described for this portion of the plan are reasonable and necessary expenses in implementing this portion of the abatement plan?
Yes, they are reasonable and necessary.
Ms. Hawkins, you have testified previously that you have experience in with evaluation plans for things like for any strategic plans that you've created in the past. Is that accurate?
Yes, I am not an evaluator, but I work with evaluators regularly.
Is it typical for evaluators to put evaluation plans together before they ascertain the dollars that they're going to have available to carry out the plan, know the scope, and know how long the dollars will be available?
There are more steps even before the evaluation plan, which there would have to be goals and objectives defined. There would have to be implementation plans in place, full assessments done about where services would need to occur, among what populations, those sorts of things. And then an evaluation team would build measures, process measures, outcome measures. They would identify data sources for each of those. They would set up methods to make sure that they can collect and get those, and then intervals of time that those things could be measured.
And you haven't been asked to create an evaluation plan, have you?
No.
I have a question before we move on.
Sure.
The last slide, you have a couple of evaluators positions. I know in looking at the K through 12 prevention and the community prevention, there's also evaluators listed. What's the difference in those roles, and why is there evaluators in both areas?
Right. So the evaluators in this particular component are overseeing implementation of the whole plan. So they're looking at the, let's call it 30,000 foot level, to make sure that the services are being delivered as designed and that the big picture outcome measures and process measures are being collected and reported on. Evaluators at the program level are working directly with that intervention. They are collecting data in the classroom. They're doing pre and post test evaluations. They are working with schools to, whether it be conduct interviews and look at reports of substance use behavior problems. So they're doing school level evaluation of the outcomes of that particular program.
And this gets back to those other evaluators. I did notice their salaries seem to be higher than even the directors. Is that common? That caught my eye.
Yeah. that can happen. We contract for evaluation services at times with universities. In terms of staff evaluators, what you'll see here is more of a consistent cost for a state employee serving in that role. Contract evaluation can be higher. You may be purchasing the expertise and the time of multiple people in that case.
Is health information exchange a part of the abatement plan that you and Commissioner White developed?
Yes.
And can you tell the court what is the purpose of a health information exchange and why is it necessary?
A health information exchange is really a centralized way in which that electronic medical records and different systems can communicate with a patient record. Having a centralized state HIE would assist tremendously with addressing the opioid crisis in a couple of ways. In the biggest way, I think we can get an entire picture of a patient's profile, no matter the number of doctors they visited, no matter the number of treatments they may be undergoing, no matter the different pharmacies they're visiting and or prescriptions they may be obtaining. In that way, you get a seamless look at a patient record, and doctors in different hospitals, in different primary care offices are able to, and even substance use disorder treatment, are able to get a profile on that patient and make better clinical judgments about that patient's care. Secondly, we know that there are situations in which I talked earlier about the PMP being integrated in the electronic medical record. There are ways in which that PMP information can be even further passed along the HIE to help coordinate care for that patient. In some cases, especially under opioid use disorder treatment, there is a disconnection between the treatment provider for addiction and the primary care provider. You've heard testimony about the need to increase the number of primary care providers that are waivered to prescribe medication for OUD, as more and more primary care providers and other specialists are initiating and inducing patients on buprenorphine and other in their primary care office, and then having to coordinate care with a substance use disorder treatment provider. These sort of information superhighways are essential to pass information back and forth.
And Ms. Hawkins, can you explain the service components of this part of the abatement plan and the associated costs and how they were arrived at?
Yes, there was a state committee that in fact looked at the potential for a state centralized HIE and had outside consultation come in and do a vision plan for Oklahoma around HIEs. These costs are derived from that work, from those experts. And in the first year to start up the infrastructure for the HIE system would be a cost of $25 million per year. In years 2 and 3, the cost would be $38 million per year. And for years 4 and thereafter, the cost would be $30 million.
And based on your education, training, skill, and experience, do you have an opinion whether a health information exchange is necessary to abate the Oklahoma opioid crisis?
Yes, it is necessary.
And based on your education, training, skills, and experience, do you have an opinion about whether the costs for a health information exchange are reasonable and necessary to implement this portion of the abatement plan?
Yes, they are reasonable and necessary.
Is epidemiological staffing a part of the abatement plan that you and Commissioner White assisted in developing?
Yes.
And can you explain what epidemiological staffing is and why it is necessary?
Yes, in this case, you've heard testimony already from one epidemiologist in the state that dedicates most of her time to surveilling deaths, for example. The number of epidemiologists that are working in these agencies to study this problem, to monitor trends and surveil this data is not adequate right now. Federal plans that speak to how the opioid crisis needs to be addressed routinely note data collection and continual monitoring as a priority need within these plans. In this case, there are many data projects that are on the list of things that need to be done in order to better understand the nature of this problem in our state, and other surveillance projects that have not been able to be accomplished yet. For example, in our state, we do not have an emergency department discharge database that requires staffing in order to examine those discharges and to develop reports on them and to analyze the meaning of the different surveillance that they're seeing. So this particular component of the plan is to increase the number of data professionals that are dedicated to addressing the opioid crisis and expanding the state's ability to utilize this data, collect this data. So I'll stop there.
So can you explain to the court how you came up with the personnel that's in this component of the plan, how the number needed and the ultimate cost?
Yes. So for the Department of Mental Health and Substance Abuse Services, we have an epidemiologist on staff currently that is funded under a grant. And that's a very tenuous way of doing long-term surveillance around public health and addiction data. In order to be fully responsive and to meet the demands of the projects that are proposed and that are necessary, the Department of Mental Health and Substance Abuse Services needs to hire 5 staff at a cost of $89,490 per year for a total of $447,450. The Department of Health, which through their injury prevention service really is the hub of the entity that is using epidemiology to understand this problem and this crisis, requires 1 epidemiologist level 3 at $91,665,000, 2 epidemiologist 2s at $76,388 per employee for a total of $152,776, and 1 epidemiologist 1 at a total of $63,672. In addition, for the State Department of Health, there are additional per employee data costs at $14,400 per year, and printing and office supply costs that equal $10,000.
And based on your education, training, skills, and experience, do you have an opinion whether epidemiological staffing is necessary to abate the Oklahoma opioid crisis?
Yes, it is necessary. And let me just clarify that epidemiologists do have special training and credentials. The title of this exhibit is Epidemiological Staffing. In the case of the Department of Mental Health and Substance Abuse Services, these employees may also be data analysts, which are support staff for epidemiologists. And so in that case, there would be an array of different levels of staffing working on this team.
And is it fair to say that you frequently work with epidemiologists to carry out the work that you do?
Yes.
And based on your education, training, skills, and experience, do you have an opinion whether the costs that you've just described are reasonable and necessary costs to implement this portion of the abatement plan?
Yes, they are reasonable and necessary.
Is data collection a component of the abatement plan that you and Commissioner White developed?
Yes.
And can you tell the court what is the purpose of data collection and why is it necessary?
Data collection has been a significant reason why I think in the state of Oklahoma we've been able to organize and implement interventions very wisely thus far with very few resources. in our state, we have existing surveys that ask questions about health behaviors, health outcomes. There are different data sets that state agencies monitor. But before and during this crisis, not every single one of those surveys or data collection methods actually had items on them measuring with specificity some of these problems. In some cases, we've had to write and get grants to add items to surveys. We've had to figure out ways to collect data by partnering on to other projects and really trying to collect at minimum what we need in order to understand the nature of the crisis. In this case, this need is really about two things. It's about developing methods to get the data that's necessary so that these personnel can have access to important information. And then also there are personnel needs where there are gaps in our agency around the ability to work in that data.
And can you explain the difference between data collection and epidemiological staffing?
Yes, so data collection, as you see here in the service, is actually the cost of implementing a survey, or the cost of developing a survey, or the cost of adding items to a survey, whereas epidemiologist is a personnel cost.
And can you describe to the court the services that make up this component of the abatement plan and the associated costs?
Yes. So the first line is about developing new surveys and new methods of collecting data that don't currently exist. There are surveys, as I've mentioned, that exist where we're able to add items, and then there are needs that have been identified where there are not resources to be able to collect information. So this first line is to develop those new surveys. The State Department of Health and the Department of Mental Health and Substance Abuse Services together require $200,000 in order to develop new instruments, new surveys, and to continue that measurement over time. The second item is to cover the cost of a youth survey in Oklahoma called the Prevention Needs Assessment Survey. This is a survey that is conducted among 6th, 8th, 10th, and 12th graders every other year in the state of Oklahoma. It measures substance use consumption patterns, and more importantly, it measures risk and protective factors that predict future use and predict future non-use. This data is collected at the local level, so we are able to look, for example, schoolhouse by schoolhouse, grade by grade, different populations, and understand what's impacting young people in Oklahoma and allow communities and schools to design plans that will be responsive to those needs at a cost of $399,244. The basis of that is to ensure that this survey can be provided to every school in Oklahoma. The last line in the service section of this component of the plan is the addition of indicators. Essentially, that means adding questions to a survey. In this case, this would be for the Behavioral Risk Factor Surveillance System, which is a CDC survey conducted across the country and in the state of Oklahoma. It allows us to compare behaviors of adults in Oklahoma to the behavior of adults in other states. It's incredibly valuable. Currently, there are very few, there may in fact only be one, I would have to check, measure on that survey regarding prescription opioid use. And to add items to that survey, there is a cost of $1,900 per indicator. So this component would be $9,500 per year to continually survey adults in Oklahoma on that survey. In terms of personnel, the Office of Juvenile Affairs and the State Health Department require additional analysts for these surveys and for this information. Currently, the Office of Juvenile Affairs has client or youth offender level data, and they do not have the capacity to analyze that data. They have been impacted by the opioid crisis and require staffing in order to help them work in their own agency data. The State Health Department, where I mentioned that the BRFSS survey is, the BRFSS survey is collected, also requires a full-time analyst at a cost of $100,000 per year.
And based on your experience, training, and skills, do you believe, or is it your opinion, that data collection is necessary to abate the opioid crisis in Oklahoma?
Yes, it is necessary.
And do you have an opinion regarding whether the costs that you just described for data collection are reasonable and necessary to implement this portion of the abatement plan?
Yes, they are reasonable and necessary.
Is NAS reporting part of the abatement plan that you and Commissioner White developed?
Yes.
And can you explain what the purpose of NAS reporting is and why it is necessary?
Yes. So in previous components of this plan, we've talked about the need to assess and evaluate for NAS within the birthing hospital setting, and of course cover medical costs for NAS births in the state. In addition to that, the Centers for Disease Control and others recommend that states have NAS as a required reportable condition. And in order to do so, there are costs involved with maintaining that database and requiring hospitals to report this data. So this particular component would fund the infrastructure, the systems, and the personnel that are necessary to oversee an NAS database or a surveillance system in the state. The first is the need to develop a database, so the technology costs that are associated with that from the State Health Department in the first year are $85,000. In subsequent years, the cost is $80,000. In addition to that, to oversee the NAS surveillance database, they require a full-time analyst at $92,187 for salary and benefits. And again, for the State Health Department, there is per employee cost for a workstation and the equipment to run that database at a cost of $5,000 for the computer software and $3,000 for the laptop and docking station.
And based on your expertise, your training, your education and skills, do you believe that NAS reporting is necessary to abate the crisis, the opioid crisis in Oklahoma?
Yes, it is necessary.
And based on your education, skills, training, and experience, do you have an opinion regarding whether the costs you just described for NAS reporting or to implement NAS reporting are reasonable and necessary expenses?
Yes, they are reasonable and necessary.
Are services and programs related to enforcement and regulation part of the abatement plan that you and Commissioner White developed?
Yes.
Can you describe to the court the services and programs that relate to enforcement and regulation that you and Commissioner White developed?
Yes. In the course of my work on the opioid crisis, I have worked at length with licensure boards and the Bureau of Narcotics, Medical Examiner's Office, and others. And even in preparation for one of my depositions, I think I met with over 12 agencies. And in the course of that, the theme from particularly the licensure boards and these enforcement agencies has been the overwhelm in cases and need to conduct investigations and have the necessary staffing and resources in place in order to respond. This component of the plan not only allows for these entities to be responsive, but to also be proactive and reduce these caseloads so that they can deeply evaluate each case and make recommendations.
And so there's several components to this, so let's just go through them one at a time. So the first relates to the Oklahoma Department of Mental Health and Substance Abuse Services. Can you describe what services are provided for there and how those costs are arrived at?
Yes, so this component of the plan is not necessarily an enforcement activity, but rather it's an activity that is performed with law enforcement agencies. This is for crisis intervention team training, or otherwise known as CIT training. This cost of $500,000 per year would allow the Department of Mental Health and Substance Abuse Services to bring this training statewide for all law enforcement officers in the state. CIT training is essentially a training in recognizing addiction and recognizing addiction crises, intervening and de-escalating situations, assisting those in the community with finding referrals and resources, and improving overall law enforcement and community relations with regard to what these officers are seeing in the community with addiction behaviors.
And the next component of this section is the Oklahoma Bureau of Narcotics and Dangerous Drugs. Can you explain to the court the personnel that comprises this component of enforcement and regulation, and what personnel is needed and how those costs were arrived at?
Yes, the Oklahoma Bureau of Narcotics and Dangerous Drugs Control had provided these costs. They are based on comparable positions within their agency. First is a criminal and civil analyst at a cost of $109,998 per year. Second are compliance inspectors. These are inspectors who are going out and working with registrants on their necessary paperwork and other regulations around their OBN registration. They require 2.5 employees at a total cost of $112,981. They are also needing compliance agents, 10 in the first year, each at a cost of $223,725 for a total of $2,237,250. And in later years, an additional 10 at a cost per $149,150, which totals $1,491,500.
And can I just stop you right there? What accounts for the difference in cost there for first and later years? Is that onboarding costs?
That's right. In the first year, Bureau of Narcotics and Dangerous Drugs Control has to support equipment costs for these new agents. Let's see, where was I?
Agents. Thank you.
Also in this component of the plan is our actual certified agents. 5 are required in the first year at a cost of $223,725 for a total cost of $1,118,625, and in later years $149,150 for a cost of $745,750. The Bureau of Narcotics also requires a full-time staff attorney at $155,854 and an expert witness evaluator at a cost of $149,150. In non-personnel costs, they require costs to cover their registration system technology at a cost of $206,000, and also to cover the costs of their collaborative work they do with other local law enforcement for a heroin and opioid task force at $450,000.
So our agency and board personnel and costs also a part of the enforcement and regulatory section of the abatement plan?
Yes.
And can you kind of walk the court through the personnel, non-personnel, and training costs associated with the Oklahoma Veterinary Board?
Yes, and for the licensure boards, there are two main types of costs that they have identified mostly, which is personnel and training for their licensees. The Oklahoma Veterinary Board requires a full-time investigator at a cost of $77,558 per year. They have non-personnel costs for mileage or car expense, training, equipment for that person in the first year and later years, and 2 investigators, an executive director, board counsel, and 1 board member to receive ongoing professional development training in the area of opioid use at a cost of $18,000.
And can you walk us through the services and associated costs related to the Oklahoma State Board of Osteopathic Examiners?
Yes. First, the State Board of Osteopathic Examiners requires a full-time prosecutor at a cost of $119,608. Support staff to assist the full-time prosecutor at $59,804. 2 full-time investigators at a total of $178,980. And 2 support staff for those investigators at a cost of $119,320. In addition to that, they expressed a need for additional office space in order to accommodate these new staff, investigators and prosecutor at $12,000 per year.
And can you next walk us through the personnel, non-personnel, and costs, services and associated costs related to the Oklahoma Board of Nursing?
Nursing. Yes. So within the Oklahoma Board of Nursing, they require a full-time prosecuting attorney at $136,188. Nurse investigators at a cost of $234,864. A legal secretary at a cost of $61,454. Nurse case managers for their peer assistance program. Their peer assistance program is to assist their licensees who are struggling with substance use disorder. That nurse case manager is at a cost of $117,432. They also require an educator for the Board of Nursing at a cost of $117,432. And this educator will work with licensees throughout the state. They have administrative costs such as rent and their administrative costs for these personnel, which total $15,660 per year. Equipment and IT costs, including some materials for training, the IT equipment for $60,000 and equipment for these $45,200.
And next, can you walk the court through the personnel and other requirements related to the Oklahoma Board of Medical Licensure and Supervision and their associated costs?
Yes. The Board of Medicine requires 3 full-time investigators at a cost of $335,588, an assistant for the investigators at a cost of $74,575, support services administrator at a cost of $74,575. Also, they require specialized training, professional development for these investigators. They have 8 investigators and training costs for $32,000. They also have a need for an expert medical reviewer, and they're estimating they will need 50 expert medical reviews, which cost them $7,000 each at a cost of $350,000. And they have one-time costs for surveillance equipment at $5,000.
And last is with respect to the boards, can you walk the court through the personnel requirements for the Oklahoma Dentistry Board and their associated costs?
Yes. They require 5 full-time investigators at a cost of $671,175. They are also asking for training for the first 5 years only for their board members, board staff, investigators, and board attorneys at $50,000. And for their 11,500 dental licensees, they are requesting training at $500 each for the first 5 years at a cost of $1,150,000.
Ms. Hawkins, can you explain why the boards need additional personnel and training and how that relates to the opioid crisis?
Yes, and in my communications with them and speaking with them in developing this abatement plan is very clear that they are overwhelmed. They are overwhelmed with the needs and the referrals that they're getting, and also their capacity to investigate each case. Their caseloads are too high, and they require additional staff. The peer assistance program, I thought, was a remarkable thing. Many of these boards participate in peer assistance programs where they're working with their licensees who are affected with substance use addiction, and many of them cited opioids as being the #1 driver of their licensees needing these peer assistance programs. So in the case of at least one board that is asking for additional assistance with peer assistance, they have remarked about really the burden that this opioid crisis has caused these boards and their ability to process through these cases and to serve their members effectively, or their licensees, excuse me.
And another component of this section of the abatement plan relates to the Office of Chief Medical Examiner. Can you walk the court through the personnel and other services that comprise this component of this section of the plan and how the costs were arrived at?
Yes. The Office of the Chief Medical Examiner has experienced this burden as well. And in my meetings with them, and we've heard testimony to this, they are having trouble keeping up, and they require more equipment and they require personnel in order to address this problem in their workload. The Chief Medical Examiner provided these components of the plan. They require additional salary for their medical examiner physicians for retention. The way that the office explained this in their need was that nationally this opioid crisis has created a shortage, if you will, of medical examiners and physicians working in medical examiner offices across the country. This has hit Oklahoma hard, not only because of our number of cases, but in addition to that, their ability to hire and retain these physicians has become very challenged. And their primary request, and the request in this component of the plan, was to support the costs of competitive salaries to retain these physicians in Oklahoma at a cost of $969,475. They also require a full-time forensic pathologist at a cost of $894,900. They require a full-time forensic chemist at a cost of $149,150. They also require 2 full-time medico-legal death scene investigators at a cost of $238,640, and this is inclusive of benefits. In terms of instrument maintenance, they have to maintain equipment that has been purchased in order to work in their toxicology lab. They would like to get as real time as possible in their ability to perform toxicology tests and have those tests read in real time when possible. There is maintenance for that equipment at a cost to their office of $250,000 per year. In addition to that, the chief medical examiner requires the need to purchase a new CT scanner. The way that this was described in their need was that the medical examiner is in some cases unable to do full body autopsies when the workloads are high, and in certain circumstances where it may not meet the criteria for that, having the CT scanner allows them to process those cases at a cost of $450,000. I'm not sure if I said that.
And can you walk the court through the last component of the enforcement regulatory section of the abatement plan in terms of the services, programs, and personnel needed and their associated costs?
Yes. So the services, programs, and personnel is required for the Office of the Attorney General to abate the opioid crisis include in the criminal justice section an annual request of $460,965. This is for 2 assistants attorney general to work with the opioid task force and insurance fraud unit. This is also for 2 full-time investigators within the criminal justice section at a total of $191,916. Also 1 support staff in the criminal justice section at a cost of $65,139. And those costs include annual salary plus fringe benefits and non-personnel costs, such as equipment and training. In addition, the Office of the Attorney General requires in the Medicaid fraud control unit 1 assistant attorney general at 0.25 FTE for annual salary and fringe benefits and non-personnel costs for a total of $25,488.75. 2 quarter-time investigators at a cost of $47,979 for salary, fringe, and non-personnel costs for a total in the Medicaid fraud control unit of $73,468. Also, legal agency counsel, the Office of the Attorney General requires 2 assistants attorney general for salary, fringe, and non-personnel costs for a total of $203,910. In victim services, $2,000 for addiction and substance abuse training and travel for 7 people at a total of $14,000. The policy and legislative development and tracking, 1 assistant attorney general for salary, fringe, and non-personnel costs totaling $101,955.
And are these services and costs again required because of, in relation to the opioid crisis in Oklahoma and the burden that's placed on this office?
Yes.
Ms. Hawkins, do you recall Renzai Stone testifying about 2 components of the abatement plan, public education and counter detailing?
Yes.
And do you recall that he testified that in his expert opinion that these services are necessary to abate the crisis in Oklahoma, the opioid crisis?
Yes.
Do you agree with that testimony?
Yes, I do.
Ms. Hawkins, based on your education, skill, training, and experience, do you have an opinion regarding how long the services and programs in the abatement plan need to be in effect in order to abate the Oklahoma opioid crisis?
Yes, I do.
And what is that opinion?
In my opinion, the services contained within the abatement plan and the abatement plan overall must be in place for 30 years. I have reviewed nothing that has called for or predicted an end to this crisis in our state. In fact, I've seen only the opposite. Recently, there have even been reports that have predicted a worsening of this problem over the next 10 years, and calls for cautious optimism for any sort of gains that have been made in the opioid crisis, as it really is too early. It's too early to tell. Oklahoma has certainly experienced recently some positive outcomes that are encouraging. But in terms of looking at a public health crisis, understanding the amount of time that it takes to develop to the point of an epidemic that we've experienced, these last few years and any sort of improvements that we've observed, we don't yet know if those are permanent. We don't yet know if those will continue. And in fact, without this abatement plan, without additional resources and being able to scale some of the services that have thus far shown some promise, I don't believe that there will be market improvement soon. In addition to that, looking at other public health crises, for example, in the tobacco field or in the tobacco control world, we are at least 20 years into active tobacco control in the United States and in the state of Oklahoma, and there have been improvements, there's no doubt, but that crisis has not yet abated. This is an overwhelming and in some ways new experience. It is a significant crisis, arguably that we have not seen before. It has taken at least 20 years to develop to this point. It will take at least that amount of time to begin to abate the problem. In my opinion, it will take much longer, and in this case, at least 30 years.
Do you think that the treatment of OUD that some of the experts have talked about in this case plays in at all to how long we need to consider, how long it's going to take to abate this crisis?
Absolutely. There have been many adverse consequences that this crisis has caused. We've talked about those, from opioid overdose death and related harm, addiction, exposures, unnecessary exposures to opioid, non-medical use, misuse that is occurring that may lead to opioid use disorder. Somebody with opioid use disorder today will have this condition for the rest of their life. It is a chronic condition, a chronic disorder. If you have opioid use disorder and you're receiving MAT, it is not, it's likely that you will continue to require medication, in some cases for the rest of your life. You've heard testimony from those affected by opioid use disorder. We also know that in many cases it's not only a chronic condition but a relapsing condition. Continual services will be required for those people today who have already been diagnosed and are even engaged in treatment, not to mention those who remain undiagnosed and untreated so far. In addition, we've talked about the impact of NAS. Just thinking forward about the future development of those infants that are born with neonatal abstinence syndrome, their families, the intergenerational impact that is caused by parents and children who are separated because of parental substance use, which we've heard testimony about and we've talked about in Oklahoma. There are many reasons why this problem will not begin to abate for some period of time. And in my opinion, it will take 30 years at least.
So you mentioned some of the testimony about neonatal abstinence syndrome that we've heard. So is part of the basis for your opinion looking at that intergenerational trauma that comes from parental addiction and how future generations are going to be dealing with this issue?
Absolutely. I'll just mention too that we're still understanding the full impact. We've talked about some of the impacts that have already been documented, but this is still quite early on in understanding this intergenerational impact. There was a study published just, I think it was a few weeks ago in JAMA, that talked about the risk to children from parents who are on opioids. What that study said is that parents who were on opioids for a year or more, their children were at higher risk for suicide attempt. I don't know that we would have necessarily predicted that. We will continue to see evidence that the opioid crisis is still growing and is still causing harm, and will continue to have an adverse effect on Oklahomans for many years to come.
Ms. Hawkins, today we went through almost every component of the plan. Based on your education qualifications, your skills and experience, do you believe that each of the programs and services that are set forth in the abatement plan that you developed and Commissioner White developed are necessary to abate the Oklahoma opioid crisis?
Yes.
And do you have an opinion as to whether each of the costs in the plan associated with those services and programs are reasonable and necessary expenses to implement this abatement plan?
Yes, they are reasonable and necessary, and in many cases, as I've tried to note throughout, particular areas where I think they're conservative. We've talked about some of those areas. For example, the NAS medical treatment cost component of the plan. In addition, the opioid use disorder treatment services component of the plan. There are many areas where candidly, it should probably be increased in some cases, including pain services for Sooner Care members that may not be afforded to all Oklahomans in this case. So yes, they are reasonable, and in fact, probably are leaning more on the side of conservative.
So, Ms. Hawkins, can you explain to the court what this slide of the abatement plan represents?
Yes, this is a table showing the first potential year of the plan being 2019, all the way down 30 years to the year 2048. It's hard to see, but the highlighted increments of 20, 25, and 30 years are, thank you, are bolded there. So you can see the totals for each of those different levels of the plan or tiers of the plan. This particular chart, though, lays out sort of an at a glance what it would look like, what the cost would look like if you could scan back out or go back out, what the total cost for the plan would be each year should the plan be funded at a different interval.
Ms. Hawkins, based on your experience, skill, training, and education, what is your opinion of the defendant's abatement plan in this case?
I'm not aware that the defendants have an abatement plan. I have not reviewed one.
So you haven't seen any sort of abatement plan that offers an alternative to what you and Commissioner White and Dr. Croft Brenzi Stone have set forth. Is that correct?
That's correct.
Your Honor, at this time, I pass the witness. Oh, I'm sorry, before I pass the witness, I forgot to do something very important, which is I would like to offer the state's abatement plan into evidence at this time.
I'm not sure what that means.
Ms. Baldwin, I think yesterday we called this Court Exhibit 97.
Yes, so what I'm referring to is the supplemental report of Dr. Christopher Room, which contains each of the tables that we've looked through, not only the tables that we've looked through today, but the ones that we reviewed with Dr. Croft, and that's what I'm referring to.
Can I get a copy of it?
And I believe I actually I have more copies, but I believe I passed out a copy of that yesterday to, that's it. Yes.
Is there a number?
Yes, there is. It is a, well, it's, what are these? So J2026 and J631. Oh, I'm sorry, we're gonna mark it as state's exhibit number.
I gave that number to the court earlier, Your Honor. It'll take us just a minute if you don't mind to find it.
State's exhibit 4734.
I had 4735.
4735?
I think there already is a 4734.
Okay, let's do 4735.
I brought that up and I think I used that number.
You did. So
but
the next number we have is 4735. Mr. Pate?
Frequently called upon to clarify numbers. I think I'm batting about 500 right now on it, but the document that Mr. Whitten marked or asked to be marked as 4734 is the same one that she is now offering as 4734. It was never offered. I believe there was an objection and we said we would offer it later. It is the combination of two documents that Ms. Baldwin already gave the exhibit numbers for.
And we marked the court exhibit. We had lengthy testimony, and for that reason, we rejected the admission of the exhibit, as well as based on all the reasons that we gave in our Daubert motion, objecting to testimony qualifications on the testimony, we reject to the admission of the exhibit.
Your Honor, they objected when I offered it because all those parts hadn't been talked about yet. Now they have.
I overruled the defendant's objection. I'm going to allow for the report to be admitted into the evidence, and we'll give it the number states 4734. All right. Could you provide a marked copy of that exhibit for the court reporter?
Yes, I will.
All right, we're going to take a quick 10-minute break before we get into the cross-examination, and then we'll be quitting around 3:30 before we do the motions to quash. Sound good? Let's start right back at 2:43.
Your Honor, I'm just going to take a minute to get you the correctly marked exhibits. Is that okay?
Yeah.
Thank you.
All right. We'll wait for Ms. Baldwin, but as soon as she's in, we'll start.
Does that happen a
You guys
lot?
can have a seat.
Does that happen
Nathan,
a
can I
lot?
go ahead?
You guys come back and people aren't here? Okay. Oh. Yeah, that's good.
Oh, yeah, sorry about that. Start with that here.
Come on in, have a seat. We will get started. And Mr. Brody, I'm going to ask you to cut off right at 3:30.
Yeah, I'm going to skip around a little bit so that we don't stop in the middle of the subject, so should be able to time it okay.
Great.
All set?
Yes.
Ms. Hawkins, you ready?
Yes.
Good afternoon.
Good afternoon.
You spoke a little bit yesterday about the 2013 state plan for reducing prescription drug abuse in Oklahoma, right?
Yes.
And you were the co-chair of that work group, weren't you?
Yes.
Along with Pam Archer, I believe it was,
That's correct.
from the Oklahoma State Department of Health, right?
Yes.
And that work group involved, I think, almost 30 people from different parts of state government, right?
I don't recall exactly how many, but yes, there were many.
And you had representatives from the Bureau of Narcotics, right?
Yes, we did.
The Board of Pharmacy,
Yes.
the Oklahoma Healthcare Authority,
Yes.
and various other parts of state government, right?
Yes.
And what you did is everybody came together, right?
Correct.
Had, I think, 4 meetings, was it?
I think it was 4 planning sessions, yes.
And-
We've continued to meet.
And then from that, you came up with a set of recommendations, right?
Yes.
The recommendations didn't come with a $12 to $17 billion price tag, did they?
We didn't actually have a budget in that plan. It was a plan setting out priority objectives for the state.
What you did have, though, if I understood your testimony correctly, was a goal, an objective, right?
We did. We had an objective around reducing opioid overdose deaths.
And the objective was to reduce opioid overdose deaths by 15%, I believe you said?
Yes.
And you indicated yesterday that the measures that were recommended as implemented have exceeded that, right?
Yes.
Opioid overdose deaths have been reduced by 43%. I
They
believe
have.
you said. Is that right?
That's correct.
Now, you don't expect that progress that the state of Oklahoma has made over the last 6 years, I guess it is, since the 2013 work group came together to just, boom, disappear overnight, do you?
I'm not sure I understand your question.
Well, we're on a good trajectory right now, aren't we?
We have started to see decreases, yes, in opioid overdose deaths.
Yeah, and yet, maybe we can show this in a demonstrative. The plan that you have put forth and set out over the last 2 days contains, first of all, no reduction outside of some implementation costs in the first year in the amount of money that is going to be spent as part of the plan, does it?
Some of the components of the plan have reductions in them.
Well, between years 2 and 30, you're proposing to spend between $727 million and $789 million in 2019 dollars every single year, aren't you?
That's the cost of the abatement plan, yes.
Right, and I think we have a demonstrative that shows that. It's demonstrative 8, Ms. Conway. And I have a copy for you. Oh, yeah, no, let's not put it up yet. I have a copy for you. Sorry about that. And, Your Honor, we would like to display this as a court exhibit, if there's no objection.
I'm sorry, we're just looking at it.
Okay.
Your Honor, I have no objection to this as a court exhibit.
May we show it, Your Honor?
Yes, you may.
And if I may approach, Your Honor?
Yes.
So, Ms. Hawkins, this sets out year by year the amount of money that is proposed to be spent as part of the abatement plan, correct?
I trust that it's correct. I don't have my chart in front of me to confirm.
And what we see is $870 million in the first year, right?
Right.
Followed by a series of 5-year periods in the plan, right?
I see that.
And that's because, as you testified to, a number of the elements run on 5-year cycles, right?
Some of them do.
For example, the SBIRT runs on a 5-year cycle, $25,000 per site in year 1, $6,250 per site in the next 4 years, and then it re-ups to $25,000 per site, correct?
Yes.
And so we see that reflected every 5 years, right?
Yes, I see an increase there every 5 years, yes.
And in general, in 2000, this is 2019 dollars, right?
So Dr. Room actually adjusted these for each year, is my understanding,
What he did,
based on an initial 2019 estimate.
correct, he used a discount factor, right,
Correct.
to estimate the present value of all of the activities running out through 2048, correct?
I believe so.
And that's what's reflected here in 2019 dollars, right?
I can't speak to that exactly. I think that would be a Dr. Room question.
Isn't that what we saw on the final grand total exhibit that you showed?
Each one of these, I haven't had time to go.
If she can actually, he's asking her a question on a document that's been admitted into evidence, so if you want to put a document in front of her so she can look at it, answer your question. Do you have a copy of the abatement plan in front of you?
I do.
Okay.
Overrule the objection.
Okay, are you asking me to confirm if each annual year that's marked on this bar graph is the annual year that's in Dr. Room's report?
Correct.
Take a moment.
I'll tell you what. The two documents, they're going to speak for themselves. This is going to be marked as a court exhibit 90,
103.
100. All right.
103.
Court exhibit 103, we'll be able to compare the two. I want you to focus on year 2049 for me, if you would.
Okay.
In 2049, it drops to 0, right?
The plan is for a 30-year period.
So in 2049, it drops to 0, right?
There's no 2049 in this chart with a 0, but the plan goes through 30 years. yes.
And then the plan would require, as it's set out right now, funding in 2049 of nothing, right?
The request is for 30-year plan.
And what's going to happen in 2049 that will allow the dollars to go to zero?
Well, so in preparing this abatement plan, we absolutely understood that we would begin to abate the problem during the course of this abatement plan. But the cost of those services to abate the problem have continual costs over time. So you don't just provide opioid use disorder treatment one time, 1 year, 5 years, and then never again. I'm not sure what you're asking.
Well, I'm just wondering, is something going to happen on January 1st, 2049 that's going to allow us to say, okay, we've abated the opioid crisis. It's January 1st, 2049. We don't need this money anymore. Is that what the plan envisions?
It's difficult to predict as we sit here what exactly the outcome will be 30 years from now, or what the data will look like. Typically what we would do in terms of setting up implementation plans is set up intervals of time, an evaluation that would allow us to monitor progress over time. In my opinion, and when working with others on this abatement plan, the plan has to be 30 years. It has to be at least 20 years. The potential for the plan to continue, you know, I'm not, is that what you're asking?
Well, I'm asking if we're going to hit some point, and from this it looks like it's January 1st, 2049, when we're going to say, okay, the opioid epidemic crisis in Oklahoma is abated, and we don't need this 700 and I can't tell what it is in year 2048 there. We don't need the $738,730,161 anymore. We don't need any.
Well, I think the problem will abate during this time.
How will we know when we have abated the opioid crisis in Oklahoma?
So part of implementing this plan will be to set up an evaluation plan that will allow us to identify measures of outcomes that will be measured over time in terms of opioid overdose death, rates of addiction, new cases of addiction, and all sorts of measures that are affiliated with these services. So that plan has not been developed yet.
So we don't know the answer to the question, how will we know when we've abated the opioid crisis in Oklahoma at this point, right?
We believe that the crisis will abate, that we will see promising outcomes, but the cost of these services are continuous, meaning we have to continue to provide treatment services and prevention services over time in order to get that result.
Now I hear you saying that the costs are going to continue, that the need for these costs and the need for these services is not going to magically disappear on January 1st, 2049. Is that what I'm understanding?
I don't know that they will or they won't. What I'm saying is that in order to provide opioid use disorder treatment, in order to abate this crisis, and the cost of serving all of those people will have to continue this duration of time. I don't necessarily know that the outcomes experienced going down will perfectly match the costs going down. Does that make sense? You have to continually provide some of these services in order to get the benefit.
Well, what are the outcome measures?
There is not an evaluation plan yet to accompany this abatement plan. We would expect to see outcomes in certain areas, but that plan has not been developed yet.
I believe you said that when you conduct an evaluation of a public health plan or a public health intervention, that you, based on your experience, you have to have goals and objectives defined, right?
Yes, and we're not at that stage here. So a significant barrier in identifying each of those measures would be knowing the scope of the resources that you have available.
So your, I guess, vision is that at some point in the future, we would define the goals and objectives.
I don't know if I'll be part of that process, but I would imagine at some point, if the court decides to award an amount towards this abatement plan, there would be a stage that would come between that decision and implementation, yes.
Okay, but sitting here today, those goals and objectives have not been defined, fair?
We may be using the terms differently. I would call it an evaluation plan where you're actually setting up measures for each of the services, and that has not been developed.
Okay, so the measures have not been set up, right?
That's correct.
And whether they're process measures or outcome measures, right?
Correct.
And we haven't done anything to set up the intervals of time by which any process or outcome measures would be assessed, right?
Would be assessed, is that what you said?
Yes.
Part of setting up an implementation plan, an evaluation plan, does include setting timeframes for doing that type of measurement. Yes.
And the reason you would set up a time frame would be so that you could actually evaluate whether you were meeting your goals and objectives, right?
That's correct.
Now, because the goals and objectives haven't yet been set up, are you therefore unable to tell me how we will know when we've abated the opioid crisis in Oklahoma?
So through the selection of evidence-based interventions that have demonstrated outcomes in each of these areas, addiction treatment, prevention, opioid overdose, NAS, we can predict with some certainty that abatement will occur. But what you're asking about is specific measures. I believe that's what you're asking, is specific measures to go with each service, and that has not been identified.
Okay, so then how will we know? How will we know when we have abated the opioid crisis in Oklahoma?
We would know through the, so two ways. So first of all, by selecting these interventions, we have some certainty because they've been tested. They've been tested in this state, they've been tested in other states, that they will produce a certain effect. Second, through the monitoring and evaluation plan within the abatement plan, where that monitoring will occur, we'll be able to monitor that progress of abatement.
So you just told me that a number of these interventions have been tested and will produce a certain effect, right?
Well, depending on the amount of research that's been conducted on each one of them, some of them raise to the level of, certain rigorous evaluations. Others are evidence-informed. But these best practices and these tested interventions, yes, we have some evidence, at least in other settings where these have been studied, that positive outcomes will come from implementing them.
So You said, and I wrote it down, they've been tested and they will produce a certain effect.
I think I said with some certainty.
Okay, and they will produce an effect with some certainty. And what I'm getting at is really what effect, to put it in your term, constitutes abating the opioid crisis. And if Your Honor, I approach the screen again.
Yes, you may.
I have confidence that through this abatement plan at the 30-year interval, that this problem can be abated at least back to the pre-1996 levels. So through the selection of those interventions, seeing their outcomes in other states, other settings, I do think with some certainty that the state can realize those achievements in that 30-year period.
And so let me just ask you, how would we know, let's say we wanted to look at, as you put it, certain effects, goals and outcome measures in, say, 2024. And how would we know if we had abated the opioid crisis by 2024?
How would we know in 2024 that we've abated the crisis, or how do we know now?
How would we know? What measure would we be looking at to answer the question in 2024, have we abated the opioid crisis?
So I'll reiterate.
Objection, asked and answered.
Overruled.
So I'll reiterate that we do not yet have an evaluation plan for the full abatement plan. What would have to occur in response to your question is that each of these components of the plan would have to have an implementation and an evaluation plan established for them. In terms of when we would know, I'm sorry, I can't remember exactly how you asked it, but there are multiple outcomes that could be measured. I have not been part of the process of developing an actual evaluation plan where those are yet defined.
So, let me see if I can get at it this way. We have this plan that's lasting 30 years, lasting until 2048, right?
Yes.
And then, as we discussed, we have no money being spent in 2049, right?
The plan is for 30-year budget, yes.
But I believe you said you don't know whether when we get to 2049, we'll be at the point where we can eliminate all the funding and say, okay, the crisis is abated. Fair?
I think I testified already that it's my belief that the state can abate the crisis in this period of time, yes.
Okay, so if that's your testimony, what do you mean by that? How are you defining it for purpose of giving that answer, that we can do it? How are we going to measure that?
There is not yet a defined evaluation plan. We've talked already at length about multiple outcomes that could be measured, including opioid overdose death, cases of opioid use disorder addiction, incidents of NAS births. I could go on. There are many.
So if you don't know what the measure is, how will you know when we get there?
Objection mischaracterizes the witness's testimony.
Sustain the objection.
Let me ask it this way. You mentioned reduction in opioid use disorder, right?
Correct, in new cases of opioid use disorder.
New cases of opioid use disorder.
Correct.
Okay. What annual level of new cases of opioid use disorder do we have to reach before we can say we have abated the opioid crisis in Oklahoma?
I would say we would have to aim to return to pre-1996 levels, minimally.
And you indicated reduction in new cases of neonatal opioid, excuse me, withdrawal, right?
NAS births.
And what level of annual new cases of NAS would we need to reach for you to say we have abated the opioid crisis in Oklahoma?
Again, I think for each of these, I would say that the aim would be to reduce those incidents down to pre-1996 levels, minimally.
And is it your testimony that on January 1st, 2049 we'll be there and boom, we can just stop spending the money?
Objection, asked and answered.
Sustained.
So let me ask you this. What happens with this plan if we get there in 2 years?
I don't think I have the authority to decide that.
Not something you've considered?
Objection is characterized as testimony.
It's a question. Have you considered that?
Have I considered if...
Have you considered what happens with the plan if we get there in 2 years?
What happens with what? The services, the money, what happens with what?
Do we say, okay, the plan worked, we're done?
I don't have an answer to that. That was not my role here, was to determine that. My understanding is that the court would determine how the money is allocated, when, how long.
All right, well, let me ask you a few questions about the process that you undertook to pull this plan together. You collected proposals for different programs and services from various state agencies, boards, and the like, right?
Well, initially, I drafted an outline of recommendations, interventions, best practices that were drawn from several sources.
All right, and you pulled all those together and you put them into your plan, right? You and Commissioner White.
That was not exactly the first step.
The first step was to engage in any necessary discussion with the board or agency that provided the information to be sure you understood what it was they were sending to you. Fair?
No.
All right. Tell me where I'm off.
Okay. I would say the first step is that we looked at data assessment in the state, understanding many of these certain problems that we've already discussed. First, we drew upon best practice documents from Johns Hopkins, the White House, the CDC. We looked at other state plans, academic literature, research, and produced an outline of recommendations to start. Then engaged other stakeholders, other agencies in reviewing that and contributing information.
And ultimately, the final product is what you have presented to the court over the last 2 days of testimony, correct?
Yes.
And the largest portion of that is treatment-related services, correct?
Yes, the category that Dr. Room provided was prevention and treatment.
Right, and he just gave it a label, right?
He grouped those categories together, yes.
Right, he didn't actually do any work to put together the substantive components of the abatement plan, right? Other than basically math.
He did review the plan, but yes. Yes.
And he basically labeled things, he grouped them. You showed us a pie chart yesterday that showed that what was grouped as treatment-related services was the biggest portion of the plan, right?
Yes, I did.
And the biggest single item within the treatment portion of the plan is the provision of treatment-related services, treatment for addiction, right?
For opioid use disorder, yes.
For opioid use disorder, right. And so I want to spend a lot of time on that because of the limited time that we have before we have to break today. I don't want to jump into T1 and T2 right away because I think we're going to spend a fair amount of time on those. But I do have a question about those elements of the plan. Do you still have S3924 in front of you? That's the two-pager. And if we can bring that up, Janice, it might be helpful. Maybe we don't have it.
It's this one.
Yes, I do. Thank you.
It's fine. And I only want to ask you one question about that document today. Who are the 35,000 people who are going to be receiving treatment for opioid use disorder under Part T1 of the plan?
Who are they? Do you mean how did we arrive at 35,000?
Who are those 35,000 people?
Okay,
I mean, I assume they're Oklahomans.
they are.
All right, so who are they?
The 35,000 was estimated doing a 9-year look back of the NSDA prevalence rates for opioid abuse and dependence for the state of Oklahoma. Taking an average of those years is about 33,400 or so estimated to be in need because of their opioid abuse and dependence. That excludes heroin. That's specific to prescription opioids. In addition to that, I think I referenced earlier that we crosswalked that estimate with other sources of information, including looking at actual claims of opioid use disorder within the state's payment system, the Sooner Care system, and then also using Blue Cross Blue Shield claims data to extrapolate the number of Oklahomans in private insurance pools that are likely to have opioid use disorder, and arrived at about 36,000. So 35,000 is a good estimate of the number of Oklahomans that likely have mild, moderate, or severe opioid use disorder.
Okay, you referenced at the beginning of your answer NSDA data, and that's the National Survey on Drug Use and Health, NSDUH, right?
That's correct.
And then you referenced actual claims within state claims payment systems, is that right?
Yes, we looked at the number of persons who have been served through state services for opioid use disorder, through Sooner Care diagnoses of opioid use disorder, and then private pay insurance estimates.
So these are people who are receiving treatment through Sooner Care, right?
No, not necessarily. They have a diagnosis.
They have a diagnosis in Sooner Care.
A claim, yeah.
They have private insurance where they may have a diagnosis in the private insurer's data, right?
Correct.
And they may have, you may know they have a diagnosis because they may show up within the Oklahoma Department of Mental Health and Substance Abuse Services data as well, right?
Correct.
And some of those people are people who, over the last 9 years, received treatment from your department, right?
No, the 9-year look back was for the NSDA data.
Okay.
But
and so how far did you look back when you were pulling together the data on people who actually received treatment through the Department of Mental Health and Substance Abuse Services?
I'm trying to remember. I'll have to look at the years we pulled for that. I don't recall.
Didn't go back 9 years, though.
I don't think we went back 9 years on that, no.
Okay, thank you for that. We'll come back to those people
Okay.
and the estimates in T1 and T2 on Monday, I guess. It takes more than 10 minutes, so I don't want to, Your Honor, jump into that now and stop halfway. Why don't we take a look at the proposal for universal screening, which is T8, and I have a set of slides that I'm going to use with this. May I approach you?
Yes.
Please don't tell me you want to do it. And if there's no objection, Ms. Baldwin, I'd like to bring up T8.
Okay, let me, would you just give me a minute?
Sure.
And you're, today, or right now, you're just asking about this one page. Okay.
Yep. T8. It should be about 9 pages in.
No objection to publication.
May publish slide T8, states plan. Universal screening.
Yes, so this T8 is universal screening, correct, Ms. Hawkins?
Yes.
And the total costs of the universal screening range from $974 million for 20 years to $1.3 billion and change for 30 years, correct?
Yes.
And there are a couple aspects of this. There's a Sooner Care Expert Services portion, correct?
Correct.
And that is universal screening that would enable all primary care. First of all, you would enable all primary care practices and emergency departments to enroll in SBIRT, and you would implement universal substance abuse patient screening and intervention for Sooner Care patients, right?
The first part that you said, their enrollment is in the SBIRT Practice Dissemination Program, which is essentially a clinical training and support program, not a service delivery program.
Now, to what extent, focusing on the actual patient screening, to what extent does, for example, let me just ask you this. To what extent does Sooner Care cover SBIRT screening?
Currently,
Correct.
there are CMS codes for SBIRT, various codes which are actually listed right here. And the state of Oklahoma has these codes open.
And the Oklahoma Healthcare Authority through Sooner Care began covering SBIRT in January of 2008, I believe. Is that right?
Sitting here, I do not know the year off the top of my head.
Okay.
There have been changes. They had initially, not all codes were open. And then there were changes to the SBIRT program in the Healthcare Authority over time.
And so as we sit here today, all codes are open, correct?
I believe so. But I'd
And,
have to confirm that.
and what this plan would do would cover expert screening for all 345,919 Sooner Care beneficiaries between the age of 19 and 64, correct?
Correct.
So this plan would have Janssen and Johnson pay for that rather than Medicaid, right?
Correct.
Why?
Well, we are here right now in a court case where we've heard testimony about the role of the defendants in creating this crisis. It's not, in my belief, the responsibility of the Oklahoma taxpayers to cover the cost of these services.
If it's already covered by Medicaid, how could it possibly be needed to abate the opioid crisis?
I don't understand your question.
It's covered today, right?
Correct.
Every Sooner Care member who avails themselves of screenings, expert screenings, those are covered by Medicaid, right?
Correct.
And so that is going on today, already happening.
Correct.
The benefits of that, whatever somebody would tell us about the benefits, those are already being realized, aren't they?
The codes are open, yes.
And all this would do would be transfer that portion of Medicaid so that Johnson & Johnson and Janssen were paying for that portion of Medicaid to the tune of $1.3 billion over the next 30 years, right?
Correct.
This includes patients who never received a single opioid medication, let alone one of Janssen's drugs, right?
I don't know if they would have or wouldn't have, but yes,
It covers all of them, right?
it does.
All 345,919 beneficiaries who fall into that age range, right?
Yes.
It's not just drug screening, it's alcohol screening as well, right?
Correct.
But this would pay for the screening for people who never had a drop of alcohol, right?
Correct.
And you've proposed funding, that $1.3 billion. It's a lot of money, right?
I think that's all relative.
You don't think $1.3 billion is a lot of money?
It is a lot of money, but relative to the opioid crisis that's been caused in Oklahoma, I think that's reasonable.
And that $1.3 billion assumes that every single one of those 345,919 people are going to get 4 screenings every year, right?
On average, some patients will visit the doctor more frequently, some less frequently.
What if somebody doesn't want to go to the doctor 4 times a year?
I can't compel people to go to the doctor, but I can tell you that in the Sooner Care program, members in Sooner Care tend to have poorer health indicators and do make visits to healthcare frequently.
So Janssen and Johnson under this plan are going to be paying 4 times every year for screenings for every Sooner Care member in 2038, right?
Yes.
Because this doesn't decline at all, right?
Correct.
There's no reflection, hey, we've made some progress, we can reduce the screenings, is there?
That's right. This is a public health approach, so you have to continue to provide the services through time. You can't take your foot off the gas in that respect.
So if we hit an outcome measure, you keep going.
Yes, we have to identify any new cases of opioid use. And let me just mention, because you mentioned alcohol, one of the reasons that...
I'm sorry, I didn't ask a question about alcohol.
Your Honor,
Okay.
she finished her answer, please. I object to Mr. Brody interrupting the witness in the middle of her answer.
Your Honor, the fact that I may have mentioned alcohol 3 questions ago doesn't mean that a witness can answer or make a comment about alcohol. Ms. Baldwin will have a chance to redirect.
Your Honor, the witness should be able to complete an answer to a question.
I'll sustain the objection. Go ahead.
So SBIRT is not only about identifying opioid use problems and referring people into care, but it's also critical that doctors and healthcare providers are asking about patients' alcohol use, particularly when making a decision about prescribing an opioid. Opioids and alcohol are not indicated together, and they increase risk for overdose death. This should be routinely asked, not only in every visit, but particularly every time that an opioid is being considered.
And so, in your view, this is a sort of best practice for a clinician, and it is a best practice for a clinician that is covered today by Sooner Care. Fair?
Yes, SBIRT is an evidence-based practice, yes.
And this proposal, this $1.3 billion 30-year plan total, it would include SBIRT screenings for Sooner Care beneficiaries who are not even born as we sit in this courtroom today, correct?
I don't understand your question.
Well, there's no reduction in the level of services for 30 years, is there?
In the reduction of the cost? No, there's not.
And it contemplates 4 times a year SBIRT screenings for every Sooner Care beneficiary between the ages of 19 and 64 for 30 years, right?
Yes, based off of the healthcare authorities' current patient load, current Sooner Care membership enrollment.
And there will be people who will move out of Sooner Care. There will be people who come into Sooner Care over that 30-year period, won't there?
Yes.
And somebody who is born next year in 2020 and is 19 years old in 2039, the plan will have Johnson & Johnson paying for their Medicaid SBIRT screening when they turn 19 in 2039, won't it?
Yes.
You made no effort, I take it, to determine the number of the 345,919 current Sooner Care beneficiaries who fall within that age range. No effort to determine the number who ever received a prescription for a Janssen opioid, did you?
No, it doesn't matter.
You could have done that, though, couldn't you?
Well, I wouldn't have done that because it doesn't matter. It's an evidence-based practice for every patient, every visit, in order to prevent new cases of addiction involving an opioid and also to identify and treat cases of addiction to an opioid.
My question was, you could have done that, couldn't you?
I don't know.
You could have looked at the Medicaid claims data for every single one of those 345,919 patients, and you could have identified every single one who ever had a prescription for a Janssen opioid medication reimbursed by Sooner Care, right?
My answer is that I would not have done that.
But you could have, correct?
Yes.
And because
Well,
you,
I suppose. I don't know what the healthcare authority, if they have that data, but if it were available.
because you did not do that, you can't tell me how many people that is, can you?
I do not know how many people that is.
All right. Your Honor, you said you wanted to stop at 3:30. I apologize, I went a minute over, but this is a good spot.
That's quite all right, Mr. Brody. Thank you. As far as this slide, rather than mark it as its own court exhibit, maybe on Monday we can take up just accepting the entire packet. That'll give Ms. Baldwin time to, a chance to review all of them and make any objections.
They're all pretty similar.
Thank you. It'll be 104.
Okay.
Well,
Thank you.
she may have an objection, so we haven't admitted it yet. But that's the number we'll reserve for it.
What time on Monday?
Come on, Judge, you can do that.
9 o'clock.
Mr. Ottaway's wearing you down.
8:30. It's been a long week. We need an extra 30 minutes. All right, that concludes the trial proceedings today. At this time, we're going to take up the two motions to quash that have been filed. We've got the one from non-party Dr. Schick and also Dr. Halford. So if I can invite counsel for the two doctors to come forward to make a record on this, and if you all would be kind enough to state your names for the record, that'd be great. Thank you, Mr. Pittman.
I'm sorry. Spencer Pittman, Dr. Halford.
Thank you, Mr. Pittman.
Aaron Dr. Schick.
That door closed right when you said your last name.
Renninger, R-E-N-E-G-E-R.
Thank you, Ms. Renninger. All right. We'll go with Ms. Renninger first. As I understand the motion that's been filed here, even though you don't contest the service, your complaint is that it would cause prejudice to his clients because of his absence for the one day that he's been subpoenaed. Is that correct?
Yes, ma'am.
What day is it that he's been
It's been
subpoenaed?
subpoenaed next Monday. As I understand it, that may not be when he's actually wanted to testify, that the subpoena leads to the hearing.
I can absolutely guarantee you it will not happen next Monday. There's
Decided on no local. So it's not.
Well, let me ask you about that, because I think your other objection is there's a video deposition and you just assume you're not cut, correct?
Yes, Your Honor, I have taught his entire week patient load. He has approximately 20 plus patients that every day next week, which would have to be moved, rescheduled. So we would request that this video deposition be read. Both parties were present. Parties did question him. It was video. And so we would ask that that be used in lieu of this live trial testimony under the statute that allows for it to be used when witnesses in
Both of these doctors, they're my subpoenas. For both of these doctors, I have no objection. I do it all the time. I'm the doctors who are busy, as opposed to having legal patients who come before one of them from Tulsa. I have no objection.
And before I invite you to respond, maybe we'll just ask Mr. Pittman, is there anything else? I've read your brief.
Proper service argument, Your Honor. Yes, I would also join in counsel's argument. Dr. Halford was deposed for 5.5 hours, almost the maximum amount allowed under the statute. This video deck really you can use for independent judgment to assess his credibility. If there's behavior on the stand, all parties are present, ready to cross-examine Dr. Halford as well. And similar to Dr. Schick, my client's going to have to reschedule patient's appointments as well. My doctor is he's a specialist. His patients schedule these appointments long prior in advance. Rescheduling is not like a prejudice then, Your Honor. It's going to prejudice my client having to essentially subsidize this costly litigation, make sure that he's going to be present for essentially an indeterminate amount of time that his practice is going to suffer. As he's also called to be here on Monday as well.
And I agree. Now, again, there's no objection to this doctor being played in videotape. I will say that served in the way he requested it, which was mailed to his office as opposed to being personally sent by the sheriff. So I honored the doctor's request in that regard. But perfectly willing to accept the deposition.
So as I see it, there's kind of two issues. One is the dates. That's not convenient for either one of you, but you've heard it from the source. That's not going to happen this Monday. The bigger issue, I guess, is whether or not to come live or not. And I guess, Mr. Ottaway, you serve the subpoenas, but if you don't care if they're here.
I don't. I think they raise good points. I do this all the time in individual cases where a doctor says, we're not coming, we file a motion to quash under the statute because of our patient, and our patient knows I get it. They've been deposed, both parties were present. I'm perfectly willing to accept their deposition testimony and play it whenever it fits into the defense case, as opposed to dragging these people halfway across the state to testify here. I don't think it makes any difference to your honor whether we're sitting there or playing on TV. So I can agree with you. Not just in this case, I do it all the time in cases where.
All right, Mr. Burge, do you want to respond?
And I'm sorry, Your Honor, one more point. The case of Young versus Macy makes it real clear that a non-party is held to even higher burden than those of parties. And the case continued on to explain that undue burden expense on those doctors. This is an alternative argument, but if the court so inclined to require the doctors to come, I would, in the alternative, request that my doctors' undue burden expenses be reasonably compensated for him having to essentially clear his workload for an indeterminate amount of time.
Thank you, Mr. Chairman.
Yes, Your Honor.
All right, make sure you speak up so we can hear you. You might even want to scoot over here.
Yeah. So, first of all, we need to separate what we're talking about. We're talking about two separate statutes. One statute deals with use of deposition at trial. That's not the statute we're under in this situation. The statute that we're under is when there's been a trial subpoena issue. And there are basically 5 reasons that they can move to quash, and Your Honor has hit the nail on the head. Undue influence, undue burden is the only one that come into play here. But Judge, we've got this case in this history. They talk about some economic problems they may have. The state of Oklahoma is required to put together a multi-billion-dollar abatement plan. But here's the deal. This is really important to us because since those depositions were taken, there's been developments that have taken place that we would need to cross-examine those doctors on. And Johnson & Johnson can bring them here if they want to. They just don't want to. And let me go over some of those things that have occurred that we would need to cross them on. Number one, there has been testimony come out in this trial that we will need to cross them on. And I don't want to go through each one of them and tell them what the cross is going to be, but I can give you some examples. With regard to the studies that they say that existed, we now have trial testimony that there were no studies. Ms. Kimberly Dean Escherman says, no, there aren't any studies. They were touted studies. There's been charts, there's been graphs, there's been court exhibits put up there. And we have taken their testimony. This was a discovery deposition. We have taken their testimony and gone back and looked at the exhibits we have, and we have exhibits that we need to cross-examine these doctors on. So, at the time the deposition was taken, we didn't know these things. We didn't know these things, and we need to be able to cross-examine them. And with regard to if there's reasonable expenses that we need to pay, we'll pay them. We need to move a date, we'll accommodate. But it is very important that we be allowed to cross-examine these doctors. Now, I don't know if they're going to offer them as experts or facts witnesses or what. They're not on their expert list, I don't think. But the stuff that we have discovered since the date of their deposition is absolutely critical for you to make an informed decision in this case. And I think that the undue burden argument falls on deaf ears given the size of this case, what's at stake here for the state of Oklahoma and the state of Oklahoma taxpayers.
Thank you, Ms. Burge.
The state judge, they had all the discovery where these depositions were taken. I can't tell you what they did or what their strategy was. The same thing applies to me. I might ask them different questions now, I might not. But they were testifying about basically how they practice medicine. That isn't going to change. Nothing in the questions is going to change. I think it's ridiculous to require them to come come here to satisfy some requirement of Mr. Burridge that he has some different cross-examination that he do now as opposed to what's that like? 60 days ago, 30 days ago?
It was February, which was long before.
February.
It was before the discovery deadline, before a lot of our expert stuff was done, and before any experts testified, so it's not the same.
Well, I disagree, and like I said, I would have a problem with it. They're my subpoenas. I subpoenaed the doctors because I think I have to, but I have no problem with them taking care of their patients. You know, it's kind of funny, the state of Oklahoma saying they're talking about how it's concerned about patients. They're perfectly willing to abandon these doctors' patients so they can get a whack at them. And I'm sorry, I don't care. I do this in every case. I think the Aaron's Fund recognize that. We work together all the time. And I think it's ridiculous to have them come down here and leave their patients.
I was just going to ask a question. What Mr. Otto just said about them working together, it doesn't make sense. You can't procure unavailability. I don't understand why the doctors were subpoenaed by y'all, and now you don't want them here. So we're fine if you withdraw the subpoenas and they don't testify.
That's not the point I said. I worked with Ms. Manager's firm all the time. Not that I was working with her here.
I understand that.
And I would make the same accommodation for her and John Wiggins or any member of her firm that they called and asked me. And I'm making that accommodation.
We just, I don't know this gentleman's name, but we just I asked him what their rate was. If the state has to pay for part of that. I'm sorry,
Judge, I just have one thing I want to add. A doctor, his patients, doctor, and his patients. They're going to bring in a ton of experts who are doctors, who have patients from all over this country. They're going to fly them in here. Presumably, that's not a problem for their patients to wait. They're paying them. They will pay them too. There's, I believe it's Clyde Muchmore's brother. I'm sorry, I can't remember his first name. John? I believe. But John Muchmore is going to walk in here just like every other witness and take that witness stand. He's a doctor and he's got patients because they ask you to. So that argument really is not wrong. And Larry's correct about one thing. We do use depositions in car accident and now product liability cases. That's not what this is. This case is important to the state of Oklahoma. Those doctors should sit in this witness stand. They should honor their subpoena just like jurors in trials. They're busy too. They have businesses. People come down here and they sit and they serve. These doctors should do the same.
My experts are going to issue, they'll be here. Dr. Stoll, they're down the street here. Dr. Phillips, they plan to testify. They can fully cross-examine. These people, the state has forever said, you go out and find doctors who can testify about their practices and how they use opioids, and it's exactly what we did. That's how they were deposed, that's what they testified to. It shouldn't be inconvenience of the patients inconvenience because of that.
It's a question of fairness.
I'm going to give Ms. Reniger and Mr. Pittman if they want the final word.
Thank you, Your Honor. Your Honor, it's not a matter of money, it's a matter of notice. I'm guessing the experts that are being brought into the courtroom were given more than a week's notice to be here. My client, who was so critical to the plaintiff's case, was given no prior notice of needing to take off to be here. I have brought his patients and his appointment schedule. As you can see, his patients are needing epidural injections and other necessary procedures to keep them pain-free.
Just a second.
We can issue the subpoenas.
He's a defense witness, correct?
Yes.
Yes.
Go ahead.
Yes. As you can see from his patient appointment schedule, he has patients lined up every day next week that have been on his appointment schedule for months. They need his medical care. To require him to cancel this at the last minute places not only him at a burden, but more importantly, his patients. So we would respectfully request the court quash the motion, or I'm sorry, the subpoena.
Your Honor, I know you said the last word on that, but we issued the subpoena when we have a reasonable basis for what the state was.
Sure, I understand that.
I mean, we gave as much notice as we thought we could.
Sure.
I'm sorry, I know you said the last word, I'm sorry.
Mr. Pittman.
Yes, Your Honor, I'd like to follow up.
Step over here because we're on the
I'll
record.
give you my spot.
Appreciate it. Just go down the line here. Last thing I want to add, Your Honor, is the subpoena statute requires
subpoenas that are served upon a party be restricted delivery. And as my motion indicated, it was not served and restricted delivery to Mr. Halpern. That's the other basis of our motion to quash the subpoena to Dr. Halpern. For that reason alone, that's grounds enough to quash the subpoena.
Sir, when I talked to him, we talked to him, he said, please service this way, burden me with personal service, and that's what we did. So I would object to that.
Well,
But may I answer? Having it served upon his business is appropriate. If he had represented that to you, that's perfectly fine, but that still doesn't mean that he cannot be restricted delivery to him. There was a brief lapse of time when the subpoena was delivered to his office, upon which he was actually given notice from his office.
we're talking about the same person that opens all his mail that he trusts and pays to open up all his other mail. So I'm not really convinced by that argument. I mean, with all due respect, I mean, it's his own office. It sounds like he gave Mr. Ottaway authority. I'm certainly sensitive to your client's needs. I am going to overrule the motions because, you know, there's a lot at stake here for Janssen and Johnson & Johnson. The state's asking for a nuisance action, and they're asking for a very large abatement plan. There's a lot at stake here. I need to be able, in my capacity as the fact finder, to, whenever possible, to be able to look at these witnesses, to listen myself, and I feel like an in-person testimony is going to be much more helpful to the fact finder. To address the inconvenience factor, if we need to reissue the subpoena, but what I would ask is give these doctors a little bit more than even the statute requires.
Oh, yeah, we'll try to give them as much notice as possible. The court's going to compel the attendance, as I've said. I've told both of these folks I'm perfectly willing to use their depositions.
Well, I'm gonna quash or overrule the motion to quash. I mean, for what it's worth, they're certainly not going to be called Monday, and I highly doubt it on Tuesday. So.
I think we'll just have to get with them and give you some guidance.
Your Honor, I told them that we would give them a date certain.
Okay.
Work them in, and we would want to stay late to get their doctors
We'll,
done. And
we will
everything.
accommodate their interests as best as we can. Yeah, we could probably even come at 7 in the morning. I know Mr. Ottaway likes to come early. We could make that. Kidding. So the bottom line is I overrule the motions to quash, and I'll direct Mr. Ottaway to work with their clients so that they can give them as much notice as possible.
So will they be required to be here?
To be here live, yes, on a date certain. No. They will not be here. The state's not even going to rest till sometime after Tuesday, and they're defense witnesses, so there's no way they're coming Monday or Tuesday.
So may I advise my client he does not need to be here?
Oh, absolutely. Yeah, absolutely.
And in terms of compensating our clients for the undue burden, are you going to be actually issuing an order in terms of compensation, reasonable compensation?
I think I need to. I'm going to ask you all to try and meet and confer on that and try to come up with an agreement. And if you can't, then you can come see me and I'll enter an order. This is awful.
I believe this gentleman. I think you said you were going to pay for everyone.
Okay.
We will pay whatever we're required to pay, Your Honor.
Yeah, this is on the order. Wait, say it now.
Whatever we're required to pay, we will pay as an administration.
Okay.
The money deal is.
Okay. Thank you all for coming down today. Appreciate it.
Thank you, Your Honor.
Thank you. Okay. Next. Yeah, let's do it now. All right. A couple of exhibits that we had today. I believe 3924 was earlier today, but we kept it here because we knew we would refer to it. So it's already been admitted that we use that. And then